Hello everyone, I am Kirti Agrawal and I welcome you back. And today I am going to teach you a very important topic, that is LMN and UMN lesion. So UMN and LMN lesion, for understanding these we need to understand the word motor. When we say motor, all our central nervous system, we have one that is your corticospinal tract, or we can call that a pyramidal tract, that is responsible for your motor reflexes and movements all over your body. But we also have extrapyramidal tracts like your rubrospinal tract and other tracts which are responsible for other kinds of movement. But today solely we are going to understand the corticospinal tract, that is responsible for the motor nerves that will go from your central nervous system to your skeletal muscles and produce a movement. So for this topic you need to understand how are the nerves being connected to each other. So all over the tract we have two nerves, okay, the first nerve and the second nerve. So for this, first understand, in the central nervous system, if this is the frontal lobe and this is the posterior lobe, in the frontal lobe we have area number 6 and we have there are 3 areas that are responsible for all the kind of movements that we have. So for area number 6 we have supplementary motor area and the premotor area. The supplementary motor area is responsible for coordination and premotor will be responsible for orientation. While the area number 4 will be your primary motor cortex, and that is for your execution of the action whatever you do. So after the nerves start from this area, it will go to the internal capsule. Now this internal capsule, you can understand that this is the anterior part, this is the posterior part of internal capsule, and this is the genu of internal capsule. You can imagine that if the nerve is going to start from here, it is going to come to the posterior limb. Now I have drawn one image over here with the face at the genu and the body at the posterior limb. So this means that all the nerves which are going to be formed will go from the posterior part of the internal capsule and it is going to go to the lower medulla. Now at this lower medulla, the nerves are going to decussate. Decussate means cross over to the other side. Okay. Now whenever we see the section of, or you can say the anterior part of medulla, you know that these are the two pyramids that we have, and this will be your olive. And if you remember, then this has your cranial number 12, and here this will be 9, 10 and 11 cranial number. So these are the areas where in the lower part of the medulla where the nerve, corticospinal tract nerve will be coming and decussating to the opposite side. Now after it has been decussated, it is like about It is about 90 to 98% of the fibers are going to decussate, while there will be just 1 or 2% of fibers which are not going to decussate and remain in the same side. Now, if this is the cut section of the spinal cord, so after it has decussated, this will be forming your lateral corticospinal tract, and this will be forming your anterior corticospinal tract. So this is the lateral corticospinal tract, and this is going to be your anterior corticospinal tract. After this, the nerve is going, this is the white matter, right? This is the white matter of the spinal cord, and this is the grey matter of the spinal cord. So nerves coming from this will go to this, where you will find nucleus in the grey matter. So these nerves are going to go here, and this will be going to the side. So the whole from this till here will be your primary, or you can say primary nerve, or the first nerve, while from here till the skeletal muscles will be your second nerve. So this first nerve will be forming your UMN, that is your upper motor neuron, while this will be forming your lower motor neuron. Now let me tell you one thing, that there are nerves from the spinal cord which goes to the skeletal muscle, but we have sensory as well as motor. So for motor to understand, we have alpha motor neuron and the second one is gamma motor neuron. The alpha motor neuron will be going to the motor end plate, while the gamma motor neuron will be going to the muscle spindles. If this is your gamma motor neuron and this is your alpha motor neuron. We also have nerves which are going to the spinal cord, but those are sensory. That will be your 1A and 1B. So there will be 1B which is going to go to the muscle spindle, while we will have 1A that is going to the Golgi tendon organs. These are responsible for your sensory reflexes. Now for today, for this spinal tract, you need to understand the alpha and the gamma motor neuron. Mostly it is the alpha motor neuron which is responsible for the movement of our muscles, while gamma motor neuron is a little bit less involved. But whenever we are going to study the lower motor neuron, the alpha motor neurons are the ones which are going to be affected. After understanding this whole path, I am going, okay, one more thing, that once this nerve is going to come here, it is always going to be an excitatory neuron. And of course, from here it is also going to be an excitatory neuron. So if this is your first and the second one, now let's see the features of UMN lesion and LMN lesion. You can just remember from a normal word, U means upper, so all the reflexes are going to be up, while L means low, means everything is going to be low. So up will be your muscle tone, all the reflexes and toe. So whenever we are seeing this, you can imagine a very strong person who is having thick muscles, and just to remember this thing, that whenever we are going to understand the UMN lesions, the muscles, because okay, now see this. If this is the primary neuron, this is the secondary one, this is for UMN, this is for LMN, and this is your skeletal muscle. Now this has stopped functioning in case of an UMN lesion. So the excitatory signals to this will be stopped. So from here, all the signals which are going to this muscles are going to be too much, which has lost control, and hence the muscles are going to be excited too much. Because of this excitation, the reflexes are also going to go up, the muscle tone is also going to go up, and for toe, we need to understand Babinski sign. And this Babinski is in UMN, all these are the features, and also one more thing, the class 9 spasticity. When we say class 9 spasticity, if you have seen a class 9, it will be easy for you to understand. But if you haven't seen, then you just have to understand that if we say the patient to move the hand and move the limb with this resistance, in the start it will not be able to move, and there will be a lot of resistance to it. But suddenly the muscles are going to relax, and suddenly the movement will be again. So it will be like this, and suddenly it will occur. So this is what is a classified spasticity. Also, to remember UMN lesion, we also have one more mnemonic, that is USB. U is for UMN, S is for spasticity, and B is for Babinski sign. So these are the things which are going to be positive in a UMN lesion. While in an LMN lesion, everything will be low. That means the muscle tone is going to go down, reflexes are going to go down, and toe will also be low. So Babinski will be negative here, while Babinski will be positive in a UMN lesion. Now to understand LMN, you can understand if this is the first neuron and this is the second neuron and this is the muscle, skeletal muscle we have, and after the excitation and this nerve is not functioning at all. So if this is not functioning, the muscle is not going to be moved. There is no movement of this muscle. But there is one thing which is called as fasciculations or so-called twitching, which is going to be positive in cases of LMN lesion. This is the reason for this is when this nerve has stopped producing any kind of signals, the muscles are going to start making more and more receptors. As the muscle makes too much receptors, there are chances that this muscle will twitch and show fasciculation. But after a long period of time, these receptors are also going to stop and the muscle will not be able to move. So for LMN, you can understand to be an old patient whose muscles are atrophied, the muscles are already too weak and they cannot move the muscles that well as compared to the other. So this is how I will this is the all topic, and for UMN and LMN you need to understand the features for them. For the reason why we are understanding this is to whenever we get a patient with some symptoms of central nervous system, we need to see the sensory, motor and also the reflexes in order to understand if the lesion is lying in your brain or in your spinal cord, or the lesion is in the skeletal muscle itself. So for this location we are deciding UMN and LMN, and hence we are going to study this. And I hope you have understand this topic very well. If you have any kind of queries, you can tell me in my comment section and let me know, and I'll definitely help you to solve your queries. And if you have any study related problem, you can talk to me in your comment section. And also, if there are any topics that you would like to understand, then please do let me know. Thank you so much.